Hi. In this video, I'm going to be talking about some of the ethical issues and dilemmas that can arise in a trauma and emergency medicine research scenario. So, in your standard research trials, there are a few key ethical ideas at play. The first of these is the idea of consent. As with anything in healthcare, you want to consent a patient and make sure they're happy with what you're doing before you do it. And the same goes for clinical trials. You want to make sure that the patient understands what you're going to do and therefore agrees to be part of this trial. And there are a few key things that you need to be part of a clinical to be able to give consent. And that's capacity, so you need to be able to make the decision and understand the decision. You need to have sufficient information, and that's to be able to understand the decision that you're making. You need to be free from coercion from either the clinician or family members or anyone else involved in the decision. And you need to be able to effectively communicate the decision that you've come to. You also, when you're a member of the healthcare team, you want to be acting in a patient's best interests, as that's why you do the job. But if you're part of a clinical trial, then there's going to be two different options that the patient could be randomized to. And you know that one of these two options isn't going to be the best option, as the other one might be more effective. Therefore, you can argue that you aren't acting in the patient's best interests if you enroll them to a clinical trial. But that's where the idea of clinical equipoise comes in. Clinical equipoise is the idea that you're uncertain about which of these two options is more effective. And that means that you're not putting the patient at any extra risk by enrolling them to a trial, and they could be getting the more effective of the two. And that allows you to continue to act in a patient's best interest despite them being part of this clinical trial. So why is this different in the world of trauma and emergency medicine? Well, to start with, the world of trauma is a stressful place. And it's difficult to make decisions in these stressful situations. And you want to act in a patient's best interests, but when you're under this stress, it can be difficult to determine what the patient's best interests are, particularly because patients' best interests usually include the patient's own values and beliefs. But if you're in a stressful situation, which is very time critical, you don't have the opportunity to determine what these patients' best interests are. So in a trauma situation, it's typically assumed that preserving life is what you're aiming to do, and then preserving function and preventing disability is your next aim. There's also the fact that in a trauma setting, your patients are going to be critically injured. This means that they're going to be often unconscious, and that means they won't have capacity, as they won't be able to properly communicate their decision. And understand and, well, take in the information that you tell them. And that means that they can't consent to be part of the clinical trial. And even if the patient was conscious, there's going to be a very stressful situation where there's a lot of people buzzing around, and again, it's time critical. So you don't want to be explaining the intricacies of your clinical trial and the benefits and risks that they may face in that situation. So it's simply not feasible to gain consent from a patient in order to recruit them to a trauma trial. So you have to look for an alternative way of recruiting patients to these trials. But then you have to ask the question, is it ethical to enroll a patient to a trial without their consent? And that's something that I think it's important to consider when you're working within trauma research. And on the TraumaOnline site, there will be a forum in which you can discuss some of the ideas that come up in this talk. So how does it normally work to treat a patient in an emergency situation? Patients are typically treated under something called the doctrine of necessity. And this essentially states that a patient can be treated without having given consent in order to protect their life and prevent serious disability. Now, there are a few key things that you have to consider when you're working under the doctrine of necessity, and the treatment you give must be in the patient's best interests, and this takes into account things like beliefs and values, as we mentioned earlier. So, if a patient has previously said that they would value the ability to perform day-to-day functions above their life, then that might affect the decisions that you make in treating a patient. And you also want your treatment to be the least restrictive of their future choices. So if you have an option that will allow the patient to wake up from their unconscious state in a short period of time, and then they're able to make a decision about their treatment at that point in time, then that's something that you should seek to do, assuming that there aren't any negative consequences that will come from doing that. So, how does it work for consenting for trauma research in emergency situations? Well, the standard process is that the lead clinician who is treating the patient will be asked if they think that the patient is suitable for the clinical trial. And the lead clinician will normally be given the information about the clinical trial prior to this point, so they'll understand the inclusion and exclusion criteria. And if the lead clinician says that they're suitable for inclusion to the trial, then the patient at that point will be recruited. They then, at a later date, will have consent sought from the next of kin, and this is assuming that the patient still isn't available. And obviously, you want to do this at the earliest available opportunity, but you also want to consider the fact that this is often a stressful time for people. So you don't want to be asking them 10 minutes later, the moment they find out that their loved one's been in an accident. You don't want to be giving them a lot of detail about the various studies that you're running. But when you have the opportunity, you should make sure that you get consent from the next of kin. And then, when it's suitable and the patient wakes up, for example, you then can seek consent from the patient themselves. Now, although these second two steps might not prevent you from providing the different care that you would have provided in the first place, if they refuse consent at these points in time, then it does mean that you'll be unable to use the data that you've gathered about this patient. Sometimes in trauma situations, patients don't survive, or a next of kin can't be identified. And in these situations, if the clinician has consented to the patient being in the trial, then this is deemed suitable, and the patient's data will remain part of the study. So we've discussed this idea of clinical equipoise, and this is something that in a trauma and emergency situation can be difficult. And this is because you want to act in the patient's best interests, and the clinician might be of the opinion that one of the two options in the study is more suitable for this patient. Now, this isn't something that should occur very commonly, and this is because normally the reason you're running a trial is because you're unsure as to whether the interventions you're working are more effective than each other, and that's why you're running a trial. And therefore, they'll typically have equipoise as to which of these two is more effective, and so if a patient meets the inclusion criteria, then the clinician should recruit them to the trial. But if a clinician doesn't feel that they have equipoise, then they shouldn't recruit the patient to the trial. And they should generally make this decision prior to the start of the trial, but if they feel that in a particular moment the patient isn't suitable for recruitment to the trial, they shouldn't do it at that point in time. So, to summarize, the patient should be recruited to a trauma trial if they meet the inclusion criteria, and this is set out by the trial when you first set it up. If the recruiting clinician has clinical equipoise and they aren't certain which of the two options that they'll be randomized to is more effective. And consent can be obtained from the lead clinician, and that's the key initial step in most situations. And then you can continue to use their data if you also gain consent from the next of kin and then eventually the patient. A patient shouldn't be recruited to a trial if obviously they don't meet this inclusion criteria, if the recruiting clinician believes that the patient is not going to survive, and this is for a couple of reasons. Firstly, some people believe it's unethical to recruit patients who are very unlikely to survive to clinical trials, and that's because it's sort of seen as experimenting on people who are going to die anyway. The other reason that it's sensible not to recruit people who are unlikely to survive is because this can skew your data. Because if the patient's going to die either way, then when they get randomized to one part of the study, then the side that they were randomized to hasn't affected whether or not they've survived. So it's essentially introducing some level of bias into your study. If the recruiting clinician believes that one of the treatment options is more effective than the other and therefore doesn't have equipoise, as we said, that means that you aren't acting in the patient's best interests, in your view, so that means that you shouldn't enter them into the trial. And if the patient or next of kin refuses consent retrospectively, then although they may have already been included in the trial and had the intervention performed, the patient's data should be removed from being part of the trial. So that's basically a summary of how research ethics works in trauma and emergency medicine. Don't forget to check out the online forum and post your thoughts about how patients are recruited to these studies. Thank you for listening.